Continuing on with chapter 28. So for history taking, obviously we need to investigate the chief complaint with everything else. If the patient's unresponsive, make sure that you use all of the sources that you have available to you, including friends, family members, medical identification, jewelry, and wallets. Cards and wallets are definitely an option. Typically, I don't do a lot of messing around with a wallet. If there's a police officer on scene, let them have it. For your secondary assessment, make sure that as you start doing your assessment, that just because the patient has the ability to walk, move the extremities, or truly feel sensation, or that they don't have a high amount of pain, does not mean that there's not a severe injury to the head or neck. So you want to make sure that you let the patient know that they need to keep still and not move their head or neck just for precautions. For physical examinations, a lot of times we're going to do a quick head to toe just to make sure we don't miss anything, but you may need to do kind of a systematic approach or a focused approach that looks at a certain area or a certain region. If your time allows, it's just better to do your secondary while you're en route rather than keeping on scene to do it. Your baselines are going to be huge for a patient that has a potential head injury, because significant head injuries are going to cause changes. So that pulse is going to start slowing down, the blood pressure is going to start to rise. And so you need to make sure you know what their baseline is for sure. If they're in neurogenic shock, the blood pressure may drop, and then your heart rate ends up going up to try and compensate, but it just doesn't work. Respirations can become erratic with either head or spine injuries. And then hypotension may be present with like cervical high injuries, or the heart rate may become slow or fail to respond to increasing in response to hypotension. You may not have those fully compensatory mechanisms that end up starting. You want to make sure that you examine for decap BTLS on the head, chest, abdomen, extremities, and back so that you know what's going on with the patient, making sure that you don't miss something. We're going to look at CMS in all extremities prior to and after moving the patient. We want to continue to see if there's decreased movement, numbness, or tingling in the extremities before and after moving so that we can tell if, or have a better clue as to if there's a significant spine injury. I'm going to look for blood or cerebral spinal fluid leaking out of the ears, nose, mouth, bruising around the eyes for that raccoon eyes, or behind the ear for the battle sign. For being able to differentiate just blood from CSF, if you take a white piece of gauze and touch it to the fluid that's leaking and then set it down for a second, if it is blood, it's going to spread pretty evenly. If it's not, if it's CSF with the blood is a lot more concentrated, so it'll stay towards the center of wherever you touch that spot too. But then you'll end up with a ring around it called a halo of lighter colored fluid, because cerebral spinal fluid is not as viscous as blood is. So it will move and spread a lot faster because it can absorb a lot more readily. It's more liquid based. And so that's called the halo test. Is it foolproof? No. But I mean, if it is definitely positive, you'll have a pretty good indicator of what's going on there. We want to assess pupil size, reaction to light, and then continue to monitor them. Don't just do it once and say, no, they're good, because as that pressure begins to build up, you're going to start seeing changes. We're not going to probe open scalp lacerations to see if it's broken bone underneath. If they have a decent sized scalp lac, mild pressure to try and control it without really pushing into the head because we certainly don't want to push bone fragments into the brain itself. And if there's an open head injury with something sticking out of it, we're not removing it. Just leave that there. You're going to want to do a neurologic examination. So get your initial Glasgow Coma Scale rating. If you use other scales like the revised trauma score, then go ahead and utilize that. That'll be depending on what service you're in, but that is kind of a newer thing. Overall, Glasgow Coma Scale has definitely been around a lot longer. Record levels of your GCS as consciousness fluctuates or deteriorates. Remember, if you have a big change in level of consciousness or orientation with your patient, technically you have a new patient. You need to start from the beginning and roll through your primary again. So here's the rating scale for the Glasgow Coma Scale. I'm not going to sit here on it for very long. And truly, do we take this down by ourselves, guesstimating where they're at? No. When you go to do documentation, it's really easy to click the boxes and it tell you what the score is. But you know, like off the bat, whether they are doing really well in that 13 to 15 range, or if they're struggling a little bit and they're in that 9 to 12 range, or if they have severe dysfunction. The lowest score that you can get is a 3. It's not a 0, it's a 3. So keep that in mind. You're going to want to look at DCAT BTLS for the spine as well as CMS. That kind of goes with both. If there is some sort of impairment, note what level of the body that's at, because you can tell where the injury is approximately located based on that. Pain or tenderness when you actually palpate the spinal area is certainly a warning sign. You palpate directly down the spine. The spine itself has muscles on either side, but truly the spine, there's not a lot of structure there that could cause pain unless there's an injury to the spine itself. Other signs include obvious deformity, numbness, tingling, weakness. Soft tissue injuries that are in the spinal region should definitely increase your index of suspicion. For your reassessment, repeat the primary, reassess vital signs, make sure that you're checking any interventions that you've done. These types of injuries to the head and spine can significantly and suddenly affect either the respiratory, circulatory, nervous system, or all of the above. So we want to make sure that we're reassessing the patient pretty much every 5 minutes, even if they are relatively stable, because we need to watch for trend changes. You want to compare your baseline vitals with those repeat signs to make sure you know what's going on. When you notice any sort of deterioration in their consciousness or their orientation, like I said, start at the beginning and go through it again, just to make sure that you know that they're not trending downhill very, very, very quickly. For communication and documentation, make sure that you provide a detailed report to the receiving facility. They may have a special protocol that they need to put in place if they have someone coming through with a spine injury or head injury. It kind of depends on where you're going, but note that that may need to be there. Keep in mind that you may need to testify as a witness. Oftentimes, these situations are because of a motor vehicle crash or tend to be work-related injuries with construction. So they're definitely looked at more closely than some of our other calls. So thorough documentation. Specific head injuries, there's really 3 main principles to protect the function of the central nervous system. So maintain an adequate airway, control bleeding to make sure that you provide for adequate cerebral perfusion, and then constantly obtain a patient's level of consciousness, assess early for that so you get your good baseline, and then continue to monitor it. The easiest way to do that, talk to your patient. If they're able to hold a conversation with you, they kind of know what's going on, they're quick to respond to your questions, then you know they're probably doing pretty good. If they start getting more sleepy, they can't quite come up with the correct words to answer you, you'll notice that change very quickly if you continue having a conversation with them. Maintaining your airway, we certainly want to open the airway, trying to keep the spine in a neutral inline position, and especially before you place the collar, but you really, that end point is securing on a backboard. If all you're doing is putting the patient in a C-collar, you still need to remind them that that's not going to keep them from moving. Make sure that you clear the airway after you've opened it for sure, and then supplemental oxygen to any patient that has a suspected head injury, particularly if they are complaining of shortness of breath or having trouble breathing. So here's taking manual C-spine stabilization while applying the collar. Circulation, if there is no pulse, go ahead and begin CPR. Active blood loss is definitely going to aggravate hypoxia because now you don't have enough red blood cells to carry that oxygen that you have. So you're going to want to start initially with controlling bleeding, but we don't want to put any pressure on the skull. Just like within any other bleeding, you don't want to remove that initial dressing. With a skull fracture, we certainly don't want to put a lot of pressure on it. So if that initial dressing becomes soaked, just go ahead and put a second one on top of it and continue to build it up like you would with most bleeding. We're just not going to put a lot of super hard direct pressure if we suspect a skull fracture. For shock, shock is usually going to be the result of blood loss somewhere from other injuries, but we have talked about neurologic shock, so that is a potential. Keep that in mind and make sure that you let the receiving facility know what's going on there. Cushing's triad. We already talked about this, but just to bring it back up. So this is an increase in blood pressure, so you have your hypertension, bradycardia or a decrease in heart rate, and then an irregular respiratory pattern. Can be either Cheyne-Stokes or Biot respirations. And again, I would highly encourage you to jump on to YouTube and find those respiratory patterns so you know what they look like. If the patient is exhibiting these signs, then you're going to want to perform controlled hyperventilation. We're not just going crazy and tripling or quadrupling the amount of respiratory rate that we normally give our patient. So we'll do positive pressure ventilations at a rate of about 20 per minute. So that's truly on just the high end of normal. We're not just crazy hyperventilating. Of course, we used to do that. We do not do that anymore. For spinal immobilization or spinal injuries, remember to follow your standard precautions. We need to maintain the patient's airway while trying to keep the spine in a proper position, giving some supplemental oxygen as necessary. Immobilizing the C-spine, you're going to make sure that you immobilize the head and trunk completely so that you don't cause any further damage. We do have long spine boards that go all the way down to the feet, just because it's helpful to do that, the full body immobilization, but truly top of the head to the base of the trunk is as far as we really need to go. So like the length of a KED. We're not forcing the head into a neutral inline position. We move in planes, which you guys have learned in the lab. We'll continue to go over that. But if it won't move, leave it alone and then stabilize it in the current position. This is showing how to do a jaw thrust maneuver. And then our C-collars we've talked about a lot. They should be applied to every patient who has a possible spine injury. It has to be a rigid collar, properly sized, and it only provides partial support. It doesn't completely immobilize the head. So we'll go on in the next video.